my name is Melissa Lamellis. I'm an occupational therapy student at Gannon University, and today I'll be lecturing on the precautions from weeks 0 to 6 for extensor tendon repair, specifically zone 1 and 2. The learning objectives for this course are as follows. So, to describe what tendons are in the process of healing, label key anatomical structures of the extensor tendons, identify the anatomical location of extensor zone 1 and 2 and the types of injury that occur at each of those levels. Memorize and explain the protocol and precautions for extensor tendon repairs, zone 1 and 2 specifically, and from week 0 to week 6. Identify the type of splint that should be used during this time. Be able to demonstrate the therapeutic exercises to prescribe to a patient and be able to explain those exercises to a patient. To be able to articulate the recovery outlook to a patient and apply the knowledge learned as demonstrated by providing appropriate responses when given a case study to analyze. So what are tendons? So by definition, a tendon is a fibrous connective tissue that attaches the muscle to the bone. The purpose of them is to be able to move the structure, to move the bone. Tendons will transfer the force of the muscle from, say, like the forearm to the fingers. So specifically with extensor tendons, the extensor tendons are running on the dorsal aspect of the hand, so the back of your hand, and they kind of work almost like little strings because they attach to the muscles here in the forearm, and they help to extend the fingers as so. All right, so on this slide I included some pictures. On the right, you'll see a lovely one of a cadaver, which shows you what the tendons, specifically the extensor tendons, look like. And then on the left, you'll see a nicer painted picture. As far as memorizing for the quiz, don't focus too much on this slide. I would like you to focus more on the slide that is coming up. Alrighty, so here's a slide I mainly want you to focus on, but before I break down what part and what aspect of each picture I would like you to focus on, I will kind of reiterate something that I kind of touched on in previous slides regarding extensor tendons. So as I mentioned previously, they run on the dorsal aspect of the hand, which is the back of your hand, and they mediate the extension or straightening of the fingers. So these tendons originate from the muscles of the forearm, and when they reach the fingers, they usually insert in either what I'm going to describe right now, which is the proximal interphalangeal or the distal interphalangeal. And you can see that on the picture to your right, which is the bony landmarks I am talking about. They are abbreviated to DIP, which will be the fingertip, and then the PIP, which is the middle. And those are the main two I want you to memorize because zones 1 and 2 have to do with those. If you look to your left, that gives you a nice clear picture of the tendons themselves. So the tendons of the flexor digitorum profundus are the ones that are going to insert at the DIP, so the tip of the finger, and the tendons of the flexor digitorum superficialis are going to insert at the PIP, so the proximal interphalangeal. Alrighty, so on this slide, I have listed all 9 of the zones. However, for testing purposes, I will only need you to focus on zones 1 and 2. So as mentioned previously, zone 1 is focused on the distal interphalangeal joint, also known as DIP, and zone 2 is the middle phalanx, so right here. On this slide, I included a picture to demonstrate the specific zones and where they are located anatomically on the dorsal aspect of the hand. Again, I just want you to focus on zones 1 and 2. So on this slide, again, I have all 9 zones listed. However, we will only be focusing on zone 1 and 2. And this list gives you the clinical significance regarding the type of injury that can occur at the zone and the physical structures that can be impacted. So as you see in zone 1, this can result in a mallet finger injury, which I'll go a little bit more into detail in the next slide, but it kind of looks like this, where the tip of the finger can no longer extend, and it almost looks like it's in flexion. And then for zone 2, an injury here involves the central slip insertion, which if you go back to slide 4, you can look at the picture on the left and it will show you the central slip. One thing to note about extensor tendon injuries are actually more frequent than flexor tendon injuries, and they are very common. About 61% of tendon injuries are extensor tendon injuries. And this is because they are not protected as well as the flexor tendons due to their superficial location. All right, so with zone 1 injuries, there are actually 4 different types. So with type 1, this would be an injury to the DIP that can be done through laceration or cutting of the tendon, jamming your finger, or avulsion where the tendon is torn away from the bone, and this will result in what is called mallet finger, which is a type of deformity that looks like so, as I had shown in the previous slide, where the tip of your finger just remains in this bent position, and it is unable to extend because the tendon that helps to pull it back has been impacted. So mallet fingers usually are treated with a splint that immobilizes the finger and puts it in a slightly hyperextended position, and that splint is to be worn for 8 weeks so that the tendon can heal. And the splint has to be worn at all times, night and day. If left untreated and not splinted, the finger will just remain in that bent position, also known as like mallet finger deformity. If that is left untreated for a long time, another deformity can occur, also known as swan's neck deformity. And what swan's neck deformity is, it is similar to the mallet finger, except you get a hyperextension at that PIP joint, and it almost looks like a swan neck, I don't know if you can see, something like that. Now for type 2, this is a laceration at or proximal to the DIP joint with loss of the tendon. Type 3 is a deep abrasion with loss of skin, the subcutaneous cover, and any type of tendon substance. Type 4 has parts A, B, and C. For testing purposes, I would like you to mainly focus on type 1 through 3. All right, so zone 2 injuries. As mentioned previously, these occur at the middle phalanx, and these injuries are usually a result of laceration or a crush injury, unlike zone 1, which is mainly avulsions. When examining, if there is an extension lag, they'll need to repair it right away with surgery. However, if the person still has active extension, meaning they are able to extend, with only a slight degree of weakness, then splinting can be used for 3 to 4 weeks rather than going straight into surgery. All right, let's discuss how tendons heal themselves. So specifically, there are 3 phases of healing. So the first one is the inflammatory phase, and this occurs right after surgery and lasts about a week. During this time, vascular permeability increases and an influx of inflammatory cells enter the healing site. These cells produce a number of cytokines and growth factors that lead to the recruitment and proliferation of macrophages and resident tendon fibroblasts that help to heal and rebuild the tendon. The next two phases are the proliferative phase and the remodeling phase, each of which the proliferative phase lasts a few weeks and the remodeling phase lasts a few months. During these two phases, the fibroblasts proliferate and begin to produce, deposit, orient, and cross-link fibrillar collagen, which helps heal the tendon. All right, so let's talk about the different types of tendon repair surgery. Now, the type of surgery depends on the type of injury and the zone in which it occurred. So for type 1, this one's usually treated non-surgically with an immobilization splint, as I mentioned before, that places the tip of the finger in a slight hyperextension, and the splint has to be worn for 8 weeks, night and day. If the patient is non-compliant, then surgery will be needed to correct any deformities. Type 2 requires a simple suture through the tendon alone or a roll type suture incorporating the tendon and the skin in the same suture and then splinting for 6 to 8 weeks following that. Type 3 fractures include a loss of tendon substance, which requires immediate grafting and reconstruction with the tendon graft. For type 4A, these are best treated with a closed reduction and then followed by splinting. Type 4B is usually treated by splinting for 6 weeks with 2 weeks of night splinting. And then lastly, type 4C with palmar subluxation of the distal phalanx is surgically treated with open reduction and internal fixation using a wire and sometimes a pull-out wire or a suture. A splint is then needed for 6 weeks after the wire is removed and motion has been restored. All right, so after covering all our bases and discussing the background of what tendons are and the types of surgery used to heal them, we can now discuss the protocol for zone 1 and 2 between the weeks of 0 and 6. So throughout weeks 0 to 6, a splint needs to be worn continuously. And as an OT, it is recommended that you provide 2 splints, one for wearing at all times throughout the day, morning and night, throughout sleeping, and then one for showering. And then it is important to note that the DIP needs to be in hyperextension between 10 to 15 degrees. Now, according to the strict protocol, the types of therapeutic exercises that should be performed during this time of healing include active assistive range of motion of the MPs and the PIPs, but not the DIPs, as they would be splinted at this time. Active PIP flexion of the affected finger with adjacent fingers held in extension. If you click on the video to the left, you will see a video demonstration on how to conduct these exercises with a patient and how to thoroughly explain their home exercise program. Alright, in this video we will be demonstrating the different exercises and stretches to prescribe to your patients who sustain an extensor tendon repair and is in the 0 to 6 week stage in their recovery. These exercises and stretches help to ensure that the uninvolved fingers will not get stiff throughout the recovery process. It is key that these exercises are performed regularly throughout the recovery as directed by the OT to prevent the repaired tendon from adhering to nearby tissues. Please note that all these exercises must be done with the orthosis or splint on at all times. All right, so the first exercise we're gonna do is that MCP flexion, so bending at the knuckle joints, and you're gonna bend and then you're gonna extend up. So with your patient, you're gonna have their elbow resting on a table, and then you can put some support on their palm and on the dorsal side of their hand, and then just ask them to bend at the knuckles while keeping their fingers straight. So you're gonna bend and then extend up. And then bend down again as far as you can, and then extend back up. And you would want them to do this about 10 times each. All right, for the next one, we're gonna do a passive range of motion stretch to the PIP joint. And you wanna do it on the affected finger. So you'll have your patient rest their forearm down with their palm up. And then what you're gonna do is you're gonna block that MCP joint, and then you're just gonna have them bend at the PIP right here. So can you bend this joint right here? Bring it up. And then you're just going to stretch it out, and you're gonna hold that stretch, that PIP flexion, and then have them extend out. And then you'll bring it back to flexion, and you'll hold that for a few seconds, and then have them extend out. You would want to do that 10 times. Now this next one's going to be similar to the last one we just demonstrated, except instead of a PIP stretch, this is going to be active range of motion of the PIP joint. So what you'll have your patient do is place their elbow on the table and lift their head up. And then you're going to want to block and support that MCP joint. And then you just are going to ask them to bend at this knuckle right here, which is the PIP. So can you just bend? And then extend up, and then bend down into flexion, and extend back up. Just like so, and you're going to want to do that 10 times as well. All right, so as we mentioned previously, the rest of the fingers do tend to get tight with this type of injury, so you want to make sure you're doing the active exercises to the rest of the fingers as well, and not just the affected finger. So you could do all the fingers at once or one at a time, whichever the patient prefers to do. But I find it easiest if you just ask your patient to put your forearm on the table with your palm up, and then you would block these MCP joints, and then ask them to bend at the PIP joint. So just the PIP, just like that. Now as you can see, she's doing it all at once, or you could do each finger at a time. So could you just do the middle finger for me? Bend at that joint and extend. Just like so. And then the ring. All right, wonderful job. All right, so for the next exercise, you're gonna be working on all the fingers, and this one is gonna be a closed fist or a straight fist. And the way that this differs from a regular fist is that you're making sure that you're not bending at the DIP joints. So you're bending at the PIP and the MCP, but you're keeping those DIPs as straight as you can. And so you'll have your patient with their elbow on the table start off in this neutral position like so, and then just make a fist width for me without bending those little joints at the end. And then go back to your neutral position, and then go back to that straight fist like so, just like that. And you'll have them do that 10 times. So this next one is a stretch to all the uninvolved fingers, because as we mentioned previously with extensor tendon injuries in zone 1 and 2, the uninvolved fingers tend to get stiff. So this stretch helps to ensure that that doesn't happen. Now you want to make sure you do this only to the uninvolved fingers and not to the affected finger. And that is because this stretch involves flexion of the DIP, which, as we know, we do not want to flex the DIP for the affected finger. So what you'll do is you'll have your patient put your forearm on the table for me with your palm up, and then you'll go each finger one by one, and you're going to curl them into flexion, and you're going to hold that stretch for a couple seconds. Now notice the MCP is flexed, the PIP is flexed, and then so is the DIP. And so you'll hold for a couple seconds and then have them extend out. Then you'll go to the next finger, and again, you'll curl it up, making sure that MCP, PIP, and DIP are in flexion, and you'll hold that for a few seconds and extend out. And you'll do the same thing for the middle finger, like so. and then you can also do the thumb. Just remember, do not do the affected finger. And you could do this about 5 times each finger. Alright, so that concludes the video for the various exercises and stretches that are to be done between weeks 0 and 6 post-extensor tendon repair surgery. So for precautions for weeks 0 to 6, you want to absolutely make sure that there is no active range of motion in the DIP. Another precaution is you want to make sure that your patient is doing daily skin checks while maintaining the DIP in that hyperextension that's between 10 to 15 degrees. You want to make sure that the splint is not causing any skin breakdown. All right, so let's touch on the functional do's and don'ts. So post-operation patients are specifically instructed by their physicians to not perform any heavy lifting or gripping with their impaired hand during those 0 to 6 weeks. Now, light activity, including activities of daily living, are permitted with the affected hand while it's in that orthosis or that splint. Activities may include picking up paper, a teacup, as long as it's less than 1 to 2 pounds. Now, when doing this, you want to make sure that if possible, you do not use that impaired finger. So say it's my index finger. See, I am picking up this cup without gripping it. Same with paper. If I'm picking up the sheet of paper, I'm making sure that my index is not holding on to it. All right, so according to the protocol, there are some other considerations to take in mind. For example, if swan neck deformity develops, then you need to splint the PIP at 30 to 45 degrees of flexion via a dorsal blocking splint. Another thing to note is that if you do not want to take the splinting route, you can also cast. And some studies have shown that this has better outcomes, so long as it's done via the constant circumferential positioning. Okay, let's talk recovery outlook. So as you can imagine, recovery of finger function can depend on the complexity of the trauma, the severity, and the anatomical zone in which the injury occurred. The repaired tendon usually will regain its full strength after about 12 weeks, but it can take up to 6 months to regain full range of motion. It is key that hand exercises are performed regularly throughout the recovery as directed by the OT in order to prevent the repaired tendon from adhering to nearby tissues. Light activity can often be resumed after 6 to 8 weeks, and heavy activity and sports can resume after 10 to 12 weeks. So this concludes the module for extensor tendon repair for zone 1 and 2 and the protocol from weeks 0 to 6. I hope you found this helpful and hopefully learned something new by the end.